Ladies and gentlemen, good afternoon. I cannot see very many of you, but I know you're there because I just walked in from behind. I'm John Graydon, and I am the Executive Director of the University of Michigan Comprehensive Depression Center, and one of the planning committee members and the kind of tri-chairs, along with Todd Sevig and Daniel Eisenberg, who have tried to arrange what we hope is an excellent conference for you. And it's an honor for me to start this day off. I'll make a comment in just a little bit, but this is the 9th conference. When we did the first one, we were doing it because of some internal reasons. We had, as campuses do, a tragedy here in terms of death of a student, and we're responding in a way of wanting to learn and share and find out what others were doing. And we had attendance from more than 50 campuses from around the country, and people said, we need to do this again. And so each year, I think it's been very easy to really find excellent speakers. But what I want to do in this very brief introduction is to thank all of you, because you're the real heroes in this. I've kind of learned to love this conference. And the reason is that I think we're tapping an unmet need that really struggles. You can have delivery systems when you're back home, and even though our health system in America has an awful lot of work and a lot of gaps, it actually, in a funny way, gets a little worse when you go off to college. And I think what we're doing is we're trying to say, what can we do to address all of the unique aspects? And I'm not going to summarize those now. But you, all of you, are doing special work, regardless of what capacity you have in your attendance here today. If you're teaching, if you're treating, if you're receiving, if you're a voice, if you're a parent, it still is special work. So thank you. The theme this year is especially relevant to, I think, our overall missions, namely early detection. The things that we're dealing with, stress, depression, sleep disruptions, suicide thoughts, substance abuse, anxiety disorders, they all tend to have peak onsets during youth, 15 to 24, things like that. And those overlap, and you throw stresses into the picture, and we've got our issues. So early detection and intervention being the overall theme is, I think, crucial. And I think what we can do is just go forward with that and learn from each other. As I mentioned, this is the 9th year of this. As I was just about to think, okay, as I introduce Greg, I was thinking next year, 10th, it's the first time, and I thought, not to distract, what we really ought to do is to say, let's not just have another conference, let's do the depression on college campuses on steroids. Bad analogy, bad metaphor, but I think we ought to do something that we could consider being a bit more special, a tipping point, a little bit more transformative, so give some thought to that, and we'll actually explore it. It's now my pleasure to introduce our first keynote speaker. Dr. Gregory Eells is a PhD in counseling psychology. He has Oklahoma State University roots and is a licensed psychologist in the state of New York. He's worked in higher education, mental health for 17 years, and he can talk with us and learn from us in the same way as in very esteemed capacity, because he's been director of a university counseling service for the past 13 years. Greg currently serves as the director of counseling and psychological services and the associate director of Gannett Health Services at Cornell. And prior to working as a counseling center director, he was the training director of an American Psychological Association accredited internship program. Dr. Eells regularly publishes articles. If you want to go chasing those, you can find his contributions in scholarly journals. As you'll hear, he's a terrific presenter, and he presents frequently. Areas of interest are relevant to all of you in the sense that it's leadership, staff morale, mental health, delivery systems, self-injury among higher education personnel, and providing care to challenging students. Dr. Eells is a member of various professional organizations and a past president of the Association for University College Counseling Center Directors. While president of that organization, he was a strong advocate for college mental health issues and did the things that I would hope all of us ought to do when we go home locally, and then if you're good enough, as he is, on CNN, which is what he's done, ABC News, NPR, and others. Dr. Eells lives in Ithaca, New York, with his wife and 3 children. His title today is a community-based approach to providing mental health support in institutions of higher education. Please join me in welcoming Dr. Gregory Eells.
Wow, it's kind of hard to live up to that introduction. Can everybody hear me? So I'm going to be talking a little bit about some of our work around community-based services at Cornell. This really does, I think, tie in very well to what this conference is about, the early detection and intervention. As you can see, and if you've heard, I've worked at Cornell for quite a while. My basic approach today is I'm going to talk a little bit about some of the groundwork, introducing the topic, talk a little bit about some of the data that we found at Cornell that really sparked us to move in some of these directions around some of the programs that we've developed. Talk about our public health framework and how that has shaped some of these interventions at the Counseling Center and the Health Service, some of the philosophy behind it, and then describe our community-based services approaches at Cornell, and then wrap up. And I want to have some time to answer questions, because I think a lot of times when I talk about these programs, I get questions, and I think there can be some really good back and forth dialogue, because I know I've already talked to some of you who have worked with some of these programs as well. So the last several years around College Counseling Center work, I think it's brought a lot of attention to our work. In some ways good, and in some ways really challenging. Issues around college mental health, as John talked about, have really raised a lot of different questions. And I think some of the questions that get raised are, how do we reach some of these students who aren't always willing to come in for care? Because there's oftentimes, as you'll see from my presentation, the students that need it most. And when I was talking to John earlier, I said the cliff notes of my talk, if some of you want to nod off, are it's not about getting students to come to you, it's about going out and bringing the care to students. So now you can slip out of it. But it really isn't about, it's not so much, it is about bringing that care out to them and finding the students that, some have said kind of crawl into the cracks. Because sometimes, for cultural reasons or other reasons, they have some real valid reasons or reluctances to seek care. And this does raise questions about how we operate as counseling services and how we operate as colleges and universities when we're bringing in everly increasing groups of students who are very, very diverse. So we are really all more challenged to develop networks of care, to integrate faculty and staff into the work that we're doing, and it's not just about the College Counseling Center. But this piece that we really came back to at our team at Cornell, and I'm sure something that many of you find as well, is that there are the students that are at greatest risk are the ones that aren't the ones walking in the door asking for care. They're the ones that are struggling and suffering in silence, and they're the ones that most need our attention and most need our focus. So some of the survey data that I talk about, and this is from Alan Schwartz's article in the Journal of College Health, that really looked at college counseling services and suicide rates. That's the thing we are all oftentimes most afraid of. It's the worst outcome. It has tragic impact on our campuses. And as you can see from his data, and this data is pretty consistent, around 80% of completed suicides are people that aren't ever going to seek out care. And Schwartz also concluded that when they do seek out care, it's a protective factor of ×6. So finding that bridge, finding that way to connect people to resources and social connections is kind of the open question. And one of the things that when we developed some of our mental health framework that I'm going to talk about, we also brought in folks from the United States Air Force, Carrie Knox, David Litz, who had done some work in the U.S. Air Force study that was really a broad public health approach to suicide prevention. And they found similar suicide rates, that about 80% of the completed suicides in the Air Force were very much the same, people who weren't going to seek out care. Another piece about suicide is, this quote is another one that I share frequently, it's impossible to predict. It happens statistically at such a low frequency that even when you take into account risk factors, even when you take into account some of the things that we know put people at greater risk, you still can't predict it because it occurs about the same rate as anyone in the general population. So those are some of the ways in which I think we feel hamstrung and that helps us, sometimes makes us feel pretty powerless in terms of responding to some of these issues. Another piece that's really gotten a lot of attention are issues of campus violence. But violence towards others in the kind of school shooter instances that you've seen are even much less frequent and much, much more impossible to predict. So, the focus that we tried to take, and I think the focus a lot of universities are trying to take, is how do you create systems where you can connect people to the services that are available? How do you connect them to existing resources? And a piece that oftentimes gets overlooked are the ways in which cultural factors and societal factors intervene that really play a role in why people don't seek care when they need it. So we looked at some of the data at Cornell, which really led us to develop some of these programs. And these are kind of common questions. Many of you use the NCHA data. Questions about being so depressed it's difficult to function. These are our Cornell numbers, which are very much online with things you've probably seen on your campus, online with what you see in a lot of national survey data, the ACHA data nationally, about 11% seriously thinking about suicide, 1.3% of actually having an attempt. One of the things that when we talk about this data that really is powerful, and we share this oftentimes with faculty, is faculty oftentimes have no idea this level of severity. It really helps kind of bring them in and ask questions about what are we doing about this? Other data that we've collected around our enrolled student survey. We looked at, and one of the interesting things here is we did break it down by racial ethnic background. And as you can see from this data, when we ask questions about being unable to function due to depression, due to anxiety, you see some statistically significant differences between people in majority culture and underrepresented minorities and international students and students of Asian American descent. So we saw some real serious gaps here when we looked at our own data. And those gaps continued when you ask questions about suicide. So we're seeing some populations who are at much, much greater risk. So you can see, again, those percentage around attempting suicide, and they carry over to thinking about suicide and also attempting suicide, which led us to think about some of those gaps. And when we looked at our CAPS data, who's coming in for care, we actually found that we did see a pretty high percentage of underrepresented minorities, but when we looked at our CAPS data, the people we were still missing were our Asian American students and international students. You can see, as we tracked that trend data in the early 2000s, that even though we saw some increase in improvement in terms of people seeking care, it was still much less than people from majority culture, which led us to think about what are some of the cultural factors that may be explaining some of this data. When we know we've got this gap between people who need the care most and they're not getting it, people who are at greatest risk, and yet they're still not seeking the services that are there to provide for them. And one of the ways we started thinking about this that helped this make sense, and this is a quote from College of the Overwhelmed. I'm sure many of you have read this book by Richard Cattison and DiGeronimo, and I think this really does kind of highlight the experience that many of our students feel, where what makes some of the bias-related instances or some of the things that oftentimes are even more kind of micro aggressions around race and ethnicity hurt worse. That oftentimes students are coming to college expecting things to be different, and they're not. And that oftentimes can lead to that gap, which you can see in this quote, leading to things like self-doubt and emotional difficulties. And I think that's a very insightful quote that really was kind of at the heart of many of the programs as we started putting them together. So the question that came from this is, how do we support the mental health of some of these students who are struggling, who we know are out there, who aren't reaching care, they're reluctant, they're unwilling, they're dealing with all these various cultural factors that are standing in the way of them getting the care that they need. And one of the Kitch article really talked about how do we develop outreach programs that directly address some of the stigmatization that's associated with mental health care and counseling services. I think a piece that oftentimes gets kind of woven into this that I just want to throw in as an aside, I'm doing this work, and I would guess most of my colleagues would probably agree with this, is we really have to kind of push against this narrative that it's all about biology. That's where a lot of times people are most exposed to these ideas are through, well, just take a pill. A pill can answer every piece of human suffering, every aspect of anxiety or sadness. And the downside of that is it's not that simple. Any psychiatrist will tell you that the drugs don't work that well. They're important, but they need to be supplemented by counseling. And if that's kind of the narrative, the damage that can be done, how it can be harmful, is that it misses the social and cultural context and can lead to people feeling very much like there's something wrong with them, when many times it is much, much more about the environment and about adjusting to a very difficult, stressful environment. And And so a lot of these programs that we've developed have really been about trying to take those things into account. So before I get into some of the specific programs that we've developed at the counseling service, I want to talk about our broader kind of public health approach to mental health at Cornell. And this is a kind of basic approach that we have been kind of working off of for about a decade. And it came about through many of our interactions with people at SPRC, Suicide Prevention Resource Center, the JED Foundation, colleagues who are here at this conference, and we looked at some of their models and adapted it to our work, specifically to an institution of higher education, to really think about it beyond even just the counseling outreach piece. And I'll start up here on the kind of about 11 o'clock, fostering an educational environment. And one of the ways when we talked about this framework, we really wanted it to be a conversation starter. So people out in our university community could say, where do I fit into this? How do I fit into this framework? What can I do to be a part of this, to support the mental health of the students on our campus? So fostering an educational environment, I mean, clearly one of the key pieces where you can involve faculty. How do you look, some of the things that we're looking at on our campus. A lot of this has really come into pretty clear focus for us after last year. Many of you are aware we had 6 suicides last year on Cornell's campus. 3 of them were from students jumping into the gorges that bracket our campus. And if you've been to the Ithaca campus, it's surrounded on 2 sides by gorges that are about 130, 140-foot drop. It's a spectacularly beautiful natural landscape, and it's also one that's very dangerous for things like suicide or even alcohol-related deaths and accidents. But we had a very rough year last year where we had these 3 deaths within about a 1-month period, 2 of them occurring within 2 days. And it really had a huge impact on our campus and it made us refocus on some of these things. And even though we were doing many of these things long before that, and one of the key lessons I took away from that was bad things will still happen. There will still be completed suicides. You can do everything right. You can do everything from all the models out there, and those things are still going to happen. However, you still can prevent many of them if you develop the kind of social connections and take a look at some of your systems from a broader mental health framework. So anyway, back to the framework, it's really led to a discussion around our educational environment. Our faculty have gotten very involved in looking at, do we need longer breaks? Do we need periods of time where we don't have serious homework assignments over the breaks? That's something our faculty just passed a resolution on. So all of those things are ways in which we can diminish the stress in the broader environment. Another component is promoting life skills and resilience. One of my colleagues, Janice Whitlock, tomorrow will be presenting on some of her work around social connectedness, which is a big piece of how we think about life skills and resilience at Cornell. How are you connected socially? How do you create living and learning environments that really are providing some kind of buffer against some of the distress that goes on and leads to some of these more serious outcomes? The kind of programs I'll be talking about will be more on this bottom half of the framework, increasing help-seeking behavior. How can you help destigmatize some of the ways in which people are thinking about their own suffering? I mean, one of the key pieces from the stigma research that I've seen is the dangerous aspect of stigma is not so much that I'm afraid you'll think less of me if I seek care. It's my own internal sense of I'll think less of myself. And I think anything that we can do to change our systems that will address that piece directly is really important. And that's where some of these programs I'll talk about address it. Also, identifying people in need of care. How do you go out? How do you kind of get the message out there that everyone in a college or university environment has a role in doing some of these things? All of us can help connect someone and identify someone who's suffering, offer them some sense of hope about seeking care and about how they can respond to the suffering they're going through. Providing quality mental health services and medical services. One of the things we do at Cornell is we work very collaboratively. We're an integrated system that can be sometimes controversial, sometimes problematic, but one of the things that I've found, the work's worth it. And primarily the way I think of the work being worth it is because it reaches more students. It provides better care for students. One of the systems that we've put in place, and I know Michael Klein's here from NYU, might talk about some of this, is we participated in their depression screening collaborative, where we do depression screening and anxiety and substance abuse screening in all of our primary care visits for medical care. So someone may be coming in for a rash, and they'll get asked questions about depression. And one of the things that we found is we've really caught or connected with a lot of folks who are really suffering who wouldn't have sought care otherwise. And having a physician, even in a very brief visit, convey a sense of hope. Oh, I hear you're struggling here. You may want to talk to Dr. Greg or Dr. So-and-so or connect with this person. That conveys a sense of of hope and a sense of confidence in counseling care that many times people from other cultures may not find acceptable, especially where they may see a physician as kind of this position of respect. So it does address some of the ways in which students may be somaticizing around their mental health issues, and this is an additional way to connect them. So that's a piece of the mental health services. Also delivering kind of coordinated crisis management when there is an event. That kind of post-vention piece is always something to have in place, because I would guess all of us out here, hopefully many of you haven't had springs like we had last year, but I know everyone here has probably been on a campus that's touched by a suicide, touched by a student death, and having the appropriate kind of responses in place is one of the ways to facilitate healing in response to that. And then a piece that we're really engaged in now is around means restriction, which on our campus, when we've looked at our suicide data, about half of our suicides in the last 25 years at Cornell have been from jumping. So one of the unique things about our Ithaca campus and this kind of natural physical environment is, in most places, jumping deaths account for about 1% to 2% of completed suicides. To have a place that's about 50% is very, very unusual. So we're in this conversation about means restriction, and means restriction most places involves locking up chemicals, locking up, not allowing firearms on campuses, providing lockers for people with firearms, those sort of things, which most places that's where you get the more frequent suicides. On our campus, it's very different. So a lot of our discussion is now about what do we do about our bridges? What do we do about our gorge edges? Currently, we have fences up, and we're in this whole discussion about does means restriction work? What's the research look like? How effective is it? And do we change some of the natural landscape when a lot of people are upset about not disturbing the beauty? How do you do that? And how do you balance some of these things around mental health and around the physical environment? So this is the kind of comprehensive approach that we've taken in our comprehensive mental health framework. So now I want to focus more specifically on our services at the counseling service. So we have clinic-based services, much like most of all of you have on your campuses. Our staff members who operate in our outreach work do a lot of general work as well. We do a telephone assessment system that's about a brief conversation to get people into care. Those assessments are available every day, all the time. That's kind of how we monitor our care, get some disposition. And we provide individual group therapy, medication management, consultation to the university, all of those things that are pretty standard. So those pieces, I think, in many ways, we're very much like any college counseling services. Our community-based services are more about our outreach programs. And in some ways, these are very traditional, too. We do a lot of the orientations, which you'll hear me talk about. But it really is, the philosophy of this team is really about supporting students who don't usually come to counseling. How are we going to maximize our efforts to the students at greatest risk? How do we overcome some of the stigma, the cultural barriers, and some of the times the institutional barriers? I mean, all of us, probably this is not shocking to any of you, but colleges and universities can be kind of siloed places. They can be pretty bureaucratic. Is that shocking to anybody out there? Making sure, I can't hardly see you, so I'm making sure you're still out there. And there's oftentimes nobody in place to kind of say, well, can't we flex this a little bit in the interest of the student? So some of our outreach work is really focused on that. And our team really thinks about the entire university community as the client. So it isn't just about the kind of individual psychotherapy relationship. It's about the whole university as our client. So our community-based service team really has been very much a team effort. You can see some of the folks that have worked on this. Matt Boone, Sharon Muir, Sonia Shropshire. I was talking to some of you out there who've worked with some of these folks, Wei Wong and others over the years, various postdocs we've had. And it has been a team effort. It's been a lot of people who've really had considerable expertise in multicultural counseling and training around multicultural and diversity issues. And the idea is about engaging students, building a relationship prior to counseling, reaching students in these alternative ways where we're bringing the counseling to them rather than them coming to the counseling per se. It's not necessarily bound by the traditional counselor role and setting, really trying to meet students where they live in their living, learning communities, addressing the problems where they occur, addressing some of the bigger bureaucratic issues, the concerns, really seeing them not so much as just being in the student's head, but being within this larger university community. And many times, even when someone is struggling with something like a psychotic disorder or something, bipolar disorder, there are still many cultural issues and institutional issues that need to be addressed. And these environmental interventions are oftentimes very essential. And the team really comes from this social justice framework perspective, a multicultural framework perspective. A lot of the ways in which these programs were developed was really to look at the American Psychological Association's multicultural guidelines and adapt those to programs. How do we put these guidelines into effect? How do we we develop programs that are really kind of making these guidelines kind of living guidelines. So again, our broader community-based services is comprised of these three prongs. The first are really more standard presentations, trainings, orientations. The second are our Let's Talk program, which are outreach, off-site, kind of walk-in hours, which I'll talk a little bit more about. And the third is our community consultation and intervention program, which we call CCI. Some people jokingly call it CSI because some of what they do, if some faculty are kind of like, it's like the black ops of CAPS. They do all this behind-the-scenes stuff that's a little different. But it's been very well received at our campus. A lot of folks really like the accessibility of it. And as you'll see, it really is about building relationships with people kind of out in the university community. I think one of the things, working at a lot of different counseling centers, common complaints are, well, we don't know folks in the counseling center, we don't know about the systems, we don't know how to connect. And these programs are about really trying to respond directly to some of those concerns. And Matt and I outlined some of this in a fairly readable article in the Leadership Exchange a few years ago. But it is about, the presentations are much similar to what all of you do. You know, those are also opportunities to meet students outside of the counseling context, get to know them, reducing barriers to care, letting them know about counseling. One of the things that we've developed at Cornell is what we call the Notice and Respond program, which our staff interacts with our mental health promotion staff. And these trainings are trainings based on films we develop with grant money, and the films show faculty and staff and students struggling with, do I reach out to a student or not? So it shows a student crying or a student depressed in their residence hall room, and other students or faculty and staff kind of, should I help? Should I go talk to them? What should I do? Well, I'll say the wrong thing, or I'll do the wrong thing. And they're about 10 to 12-minute videos, and then we have discussions. And what we found, the way to get these to work is we have these trainings in mandatory meetings. One of the things about outreach that sometimes gets problematic is you end up preaching to the choir, and you don't get the people sometimes that you need to get. So we found ways to try to make sure we're at mandatory student meetings, mandatory RA training meetings, mandatory faculty and staff meetings. And this is a piece of these kind of standard outreach. And we found these videos really open up the conversation around mental health. What's my role as a member of a community? How can I play a role in conveying a sense of hope? How can I play a role in saying, you know, I care about you. I don't have to be your therapist, but I care about you, and here are some people you can talk to. And that's really where those videos come from. And some of these programs are outlined and talked about on our Caring Community webpage, which you can't really see in the print there, but it's in the handout. So our Let's Talk program. So here's kind of the best description of our Let's Talk program, the adaptation of Lucy. She's got a little Cornell shirt on, if you can't see that. The doctor is in. And it is free, and it's even less than 5 cents. And Let's Talk, we really think about it, is students oftentimes come to that. They're too anxious to do a phone assessment. They're too anxious to kind of take that first step. And these are out on nine different locations, and it really helps lower that barrier to care. It really personalizes that first contact. You can just kind of drop in to a place you feel comfortable and talk to somebody. Mitigate some of the discomfort from the phone triage. The phone triage is a great way for us to manage the inflow of all the people we're seeing, but it also is somewhat off-putting. And so Let's Talk is a nice complementary service to that. If a student wanting counseling wants to access if that's a little bit too hard, that's where CCI kind of comes in, our Community Consultation Intervention Program. So all these services kind of fit well together. One of the things that they do is they also allow our phone assessment system to be more efficient, and I think does minimize our dropouts to that program. So Let's Talk, you can see our Let's Talk website. The Let's Talk program, like I said, has about 15 schools that are now involved, has a listserv where staff talk about different ways to develop Let's Talk programs. We have daily availability across campus where somebody can just drop in and talk to somebody. 9 different locations, it's free. Part of being out there too is about connecting with people in the community. So our counselors, some of them are in the Asian Studies program or Latino Studies program. And we're connecting with the support staff there. So our counselor will show up at 2 on a Friday afternoon, and the secretary in the Latino Studies program will say, hey, so-and-so is struggling, and I told them to drop by today. And it allows that kind of bridge. It allows a lot of times staff out there not to feel like they're holding these students alone, which many times support staff or academic advising staff, that's exactly how they feel. So it really provides a bridge for them to connect. So you get these direct referrals from trusted members of the community, which is incredibly valuable. You're outside of the counseling center, health center. You're doing much more kind of consultation support. It's not psychotherapy. We don't advertise it as psychotherapy at all. If psychotherapy or counseling is what you need, then the role is to kind of get them into the counseling service. So there is that that kind of referral piece, which is some of what you do, you see on the bottom. But a lot of it is very much about this can be anonymous. We'll meet you where you are. You don't have to fill out a confidentiality statement. It's more verbal, and the focus really is on solutions, resources, advocacy. And most students only come once, some twice. If someone's coming a lot more often than that, we'll really try to say, if you need more than this, what you need to do is go to the counseling service. So it really is about trying to keep that engagement in place. So here's some of the ways in which we advertise on campus. So this is we have bookmarks that we hand out all over campus. It's got access to the website. It's very kind of simple, conveying some of the kind of cultural message we want to convey. This kind of broad, general Let's Talk advertisement. And then we have some that are more specific, that advertise the different locations. And one of the things about the Let's Talk program, as we conceptualized it, was to not make any assumptions about what the student needed around care. So sometimes, like, for example, we would have a counselor in Ujima, which is our African American Living Center. But sometimes that was the last place an African American student would want to go to see a counselor. So they would go like across campus to the law school because that was not where they wanted to live. It felt a lot safer. Sometimes that would be the first place an African American student would want to go. But our conceptualization was don't make assumptions about that. Part of doing cultural work is not assuming you know what somebody else needs. And so that's really how we thought about these different sites and how we thought about placement and accessibility of these different sites. So that's the Let's Talk program, and I'll have open that up for some more questions about that if people have it later. Our other program is Community Consultation and Intervention. And this program is somewhat similar to what many of you have on your campuses, which oftentimes is a care management, case management person, but it's probably a little bit different in its conceptualization. Staffed by 2 psychologists right now for us, Sharon Meir and Sonia Shropshire, and their work is very community focused. They don't generally see hardly any clients in the standard 50-minute psychotherapy hour. Their work is comprised of all these different components, which I'm going to get into. So consultation, case management, some kind of basic counseling and support, training in the sense that it's much more individualized. It's much more coming from their interpersonal relationships with academic advisors and various faculty. Some advocacy, and then crisis intervention. And this was adapted from an article, as a resource I have in here, written by Sharon, Matt, and Sonia in 2009, and then our manual that we use for the program. So consultation. Really, this is much more about individual consultation with support staff. And sometimes CAPS clinicians, sometimes health service clinicians. So their role is very much to kind of fill those gaps that oftentimes get created in our work, where people are thinking, I've got this piece, somebody else is thinking over here, I've got this piece, and many times there are gaps between those various pieces and those various silos. And their role is really to fill that. They're really kind of the glue or the mortar that brings those pieces together. They participate in college advising meetings sometimes. They will come to those regular meetings, help the whole advising staff strategize about how they may deal with certain types of student cases. They'll meet with residential program staff and be in various meetings of various other units where they're in those places, they're establishing those relationships. It really is very much about building those relationships when you're not in a crisis. Because when you are in a crisis, that's when these things get much harder to deal with. That's when it gets a lot more difficult and a lot more challenging to respond effectively. So the goal of the program really is to conduct networking and consulting in other locations on campus. They have offices in the counseling center, but they're oftentimes out in the world, out in the college, university, community environment. And many times, a lot of what they do is they suggest changes in the program. So one of the great examples around this was around academic integrity. One of the things that we found is that around academic integrity, it wasn't always so simple that someone was just cheating. One of the things we found is very, very intelligent people were self-sabotaging, cheating in ways that they knew they were going to get caught. There were oftentimes very much cultural variables at play, family variables at play, students in programs that they didn't want to be in but were in those programs for their parents. And there were all these kind of factors that played a role in academic integrity, that it wasn't just as simple as a lot of times our colleagues in the advising office thought. And the way our CCI staff worked on this was really changing the ways in which they managed academic integrity, looking at it in a broad way, not in a way that students would escape consequences, but at least sharing with some of the ways in which these more complex factors came into play around academic integrity. So that was a key piece around how it changed some of their programs, where it broadened the ways in which those other folks on our university campus saw these kind of situations. Other programs that have changed for these consultations, the ways in which students were notified about if they had poor academic performance or other things, or if they were going to have to take a leave from the college, really trying to make sure before a student got that information, we put in place at least some way to connect with them socially. Because we found when students got a letter or other things, they were very, very vulnerable for having a suicide attempt or some other kind of mental health challenge. So putting a system in place and a structure in place where there was that support there prior to getting that news, and we were partnering with them, they felt better about it, we felt better about it, and I think our students generally felt better about it. So that's kind of where some of those consultation pieces came into play. Another big piece of what they do is case management. And this is really the best way to describe it is what I said. They're really pulling together all of those different pieces of the university, where when a university can get very broad, very bureaucratic, very siloed, there's no one there to kind of be the glue, to pull all of these various different pieces together. But they can really do a great job. They can oftentimes be a conduit to get a student on a health leave. I mean, health leaves for many of our students who are struggling academically are a great option. They can help work with the graduate school, switching advisors, switching labs. Our graduate school is pretty decentralized at Cornell. And many of our graduate students end up, and some of you, I'm sure many of your universities find this the case as well, if they have a relationship with a graduate advisor and that relationship sours, there's not much else for that student at that university. They need to switch labs. If they can't work with that person, their career at Cornell as a graduate student can end. And there's oftentimes no one there to kind of pick up that piece on our campus. So our CCI staff oftentimes are involved in helping facilitate some of these moves from labs, move to other advisors, and sorting through some of these things. Sometimes it means what's best for the student is to transfer to another university. So kind of working with some of the academic pieces. And sometimes it is an intervention to sort out some type of injustice. Sometimes the bureaucracy, sometimes the faculty members may not always be acting in the student's best interest. And we do have care managers at the health service. So and care managers' roles are oftentimes working with students who have these kind of overlapping mental health issues and medical issues. So sometimes they may kind of be the person who gets that person to that level of resource as well. So they're very much in this kind of case manager, community psychology role that is very unique. Other pieces. So they do some kind of more informal counseling and support when they're out in the world. So if a student is very difficult to get into care, that's really their role. One of the kind of key examples recently from their work was a graduate student who was seeming very clearly psychotic to the undergraduate students he was teaching, to the professor who was supervising him, but nobody knew how to respond. Nobody knew what to do. It wasn't quite clear enough what the next step should be, yet it was very disturbing. And their role was to kind of go out, talk with the student, do some very informal counseling and support, get the student to agree to come into the counseling service, be evaluated by a psychiatrist. We talked to the student. In that instance, it became very clear that the student needed to go to the hospital, and that's what happened. But without the CCI staff in that role, it could have been a much more challenging situation and one that would have maybe not worked out quite as smoothly. So their role is to really go out and kind of do that informal counseling and support role. The counselors may meet with students in one of the colleges. They do a lot of meeting out of the center to kind of, again, normalize the care, destigmatize some of the care, take into account some of these larger cultural factors, and especially for many of these students who aren't going to be interested in coming in for formal counseling. And when a student begins working with a CCI staff member, the nature of the work can be determined between them. Sometimes a CCI counselor will kind of take a few students on their caseload that are really hard to transfer, so they will see a few, but generally their work is very unstructured and out in the community. And sometimes they will transfer them to another person within the counseling service. The trainings that they do, their trainings are much more individual. They're not the kind of didactic trainings that many of us think about. It's very much about sitting down with a couple people in an academic advising office, in a college office, and walking them through how you can respond to this student. Here are some things you can say. Here are some resources you can direct the student to. That they're really developing these strategies to help students in specific case-by-case ways, and providing specific guidance, specific training. And it really is oftentimes about students that the student may not think that there's a problem per se. That's why they're not seeking care. But they are oftentimes disruptive or upsetting to the university community. And again, that's where we see our role of working with these other very important partners, that they're our client. This larger university community is our client that we're working with. And they also do a lot of work with our Gannett mental health promotion staff. They do a lot of work with Notice and Respond, making sure all the messages are consistent around the resources that are out there and how you can intervene and how you can respond. Then they do a lot of advocacy. And one of the hard pieces around advocacy is, many times this is this kind of tough intersection between conduct and student mental health issues. That students may have conduct violations or run afoul of the judicial system because of some mental health issue. And what we found is there aren't a lot of advocates on our campus when those things happen. So our CCI staff end up kind of falling into that place. When there's an injustice or inequality or misunderstanding, they can oftentimes advocate on a student issue. They can work with the student to do some of the course changes and other things that I talked about earlier. They really try to stay focused on what's in the student's best interest, but they are, like all of us, always having to balance this interest of individual safety versus community safety, and they're oftentimes on that front line of really being the people who have to respond to that. And then they do a lot of crisis intervention. This is where they do a lot of wellness checks with students. They work very closely with the police. Where a student is in distress, they're not known to the mental health service, but other people on campus know about them, worry about them, or a student maybe hasn't come into counseling or hasn't come into class for a long time and people are worried. So they're oftentimes the ones that see these first signs of distress through faculty and staff and academic advisors. They really develop intervention plans. It may include the wellness check with the police. It may include facilitating some type of hospitalization, like in the case that I talked about before, and helping to connect the student to family or other support staff. So these kind of crisis intervention pieces are huge. And part of the crisis intervention, which also kind of overlaps with advocacy, is they do a lot of work with financial aid. Sometimes there are students helping students' funds or money that can be brought to bear on situations where that's the key stressor for a student. So they really take that kind of role, which is really important. So some of the larger administrative benefits of these programs that I see and really value as a counseling center director. Campus staff who are out there, our key advisors, people we really needed to support our work in the counseling center, are much less likely to find themselves alone in responding to these kind of cases. They feel like they've got an active partner in supporting students when many of these problems oftentimes do feel much bigger than they can handle, not being someone trained as a mental health professional. Residence life staff, academic advisors, student affairs staff, they have a much clearer sense of how you access the counseling service, what the counseling service is about. These, Sonia and Sharon are very much out there explaining kind of how our system works, the counseling center, the health service. They're very much a bridge to what sometimes feels like a black box given, confidentiality rules and other things that we all have to operate under. They can provide alternative referrals for students who are not going to kind of come in or maybe reluctant to use Let's Talk and those other programs. And what we have found is it definitely does improve how people think about the counseling center. It very much humanizes our work with students, faculty, and staff, and the whole campus community. Another key piece, which we've seen an advent on most campuses now since Virginia Tech and Northern Illinois, are development of kind of student concern teams, behavioral intervention teams, threat assessment teams. All these kind of teams are important. They become almost a standard practice. And our CCI staff does a lot of work with this team. There's considerable overlap in functions. They really integrate their work with the team's work. They consult on the cases. They're at every one of our weekly team meetings. They oftentimes do much of the work, spearhead the intervention, when there really needs to be a clinician kind of on the ground, trying to figure out what needs to happen next, what level of care is appropriate, what level of response is appropriate. And they play a very large role when there's a psychotic student or disruptive student who's not accessing service, who's not willing to kind of take that first step, and yet the university community is concerned. They really do provide a very, very clear disposition, a clear avenue for what we're going to do and how we're going to respond as a larger university and how we think about those things as a larger staff. So some of the administrative challenges. One of the biggest questions we get around Let's Talk and CCI is, well, how do you document this work? And one of the things that the kind of answer that we came up with this as we consulted with our counsel's office was these are still kind of, if you're a psychologist or social worker doing this kind of work, Let's Talk or CCI, you have to write something down. But we put that in the part of our chart which is not releasable, our kind of third-party correspondence section where we don't release those records. We do have that option of an anonymous visit, so we'll put anonymous in, describe the situation, not tie it to a student. So our counsel's office has been okay with that, where there's some of that protection. And just having that, hardly any students in Let's Talk request that. It's maybe 3 to 5%. Or they'll request it for the first visit, come back for a second and tell you. But having that there really is a great way to lower some of these barriers and help students feel like they can be engaged where they are. So we don't release those as part of our standard process. So we are keeping some record, but it's not part of the standard health record. It's a little bit of a compromise. compromise. And that's one of the biggest challenges that took us a while to work out. So some of the directions of where we want to go with our program. And a piece of it is doing what I'm doing now, sharing it with you, hearing feedback from you, thinking about different ways we can all bring to bear some of the things that I've talked about in this presentation. Figuring out ways, how do you systematize the work without, and make it somewhat a part of your institutional work that as staff leave and turnover, it continues because it's really good work. How do you figure out how to do that? How do you get more people involved, more people aware of it, and then hopefully more students involved and connected? I think one of the key pieces for us are some of the ethical challenges of these situations, how you balance things like confidentiality. What does it mean to have the whole university as your client? That's a very, very hard thing. One of the things that we're allowed to do in psychotherapy is when you have a client, there are a lot of boundaries around that work. It's clear what the roles are. The roles get a lot more blurry when the whole university is your client. So that kind of issue of where are the boundaries, where do we take that from here is an important one. But I think the piece that I really take away from this is I think many of us at all of our universities are thinking about how we're going to respond in this broader public health perspective. That it really is not just the counseling center's responsibility, the counseling service's responsibility to respond, that we all play a role. How do we partner better in some of this? And I think these programs really provide very important, clear avenues to do those things. That this kind of culturally informed work, connecting multicultural guidelines, this very culturally informed care that kind of steps out of some of the assumptions that are very rooted in kind of more Western perspective is really important. And yet, how do you kind of bring about teamwork, the confidentiality pieces I've talked about, think about the ethical dilemmas. All those things are key pieces of this. But I think we all do have a role. We have a role in kind of thinking about evaluating and modifying our programs at Cornell, as well as how we can share those and get feedback and modify it as we talk to many of you across campus. And so here are two of the articles that I've already talked about as resources. And I did just want to stop here and open it up if people have questions or comments or things that they would like to respond to. Yeah.
I'm Robert Winfield, the Health Service Director here in Ann Arbor. Could you describe more about the distributed counseling centers, this concept of 9 centers? How does it work? How do you make it effective for students? How do you staff them?
Sure. So, I mean, the primary answer is they're not counseling centers. So one of the things that we get key partners across the university to say, we'll give you an office space. Sometimes it's right next to Latino Studies program or some other office where their front office staff kind of serves as our front office staff. They really are drop-in. If somebody's in with somebody for 20 minutes, the person there will say, well, they'll be out in about 20 minutes, just wait for a little while. So each site takes on a little bit of life of its own, and it's very much a collaboration. Some sites where we don't have a person in that administrative role, there's a piece of paper and you can slip it under the door, letting them know they're there, and the counselor can kind of wrap it up and keep these contacts very brief. But each of them takes on a little bit of a different operation in terms of how they operate. I mean, they are all staffed by licensed psychologists and social workers, so they're operating under the state confidentiality provisions, but it's much more kind of verbal, and it's much more informal in that sense. We have an FAQ on our Let's Talk website that goes into some of those things in more detail, but they are kind of the nuts and bolts of how they operate oftentimes depend on exactly where the sites are. And like I said, we've had a lot of different places, from our Arts and Sciences Advising Office to the law school, the vet school, various programs like Latino Studies program, African American Living Center, various residence halls, and all of them are a little bit different depending on how they fit with that culture, and how they fit with the structures and supports that are already there. But that's generally kind of how they operate, yeah.
And are the people full-time at that site, or are they?
No, so each site, there may be 2-3 hours a week. So there's 9 sites, and there may be 2 sites on Monday, 1 at the law school, 1 at Arts and Sciences. So there's really just a 2 or 3 hour block at each one of the 9 sites. But there's a Let's Talk site, usually 2, most days. Friday we have a little less. We tweak the utilization based on, or tweak the location based on the utilization of the data we collect. So, thanks, Robert. Yeah.
Hi, Melvin McGinnis, the Depression Center. I'm still sort of struggling with formulating my question, but one of the things that I'm interested in is how you are sort of categorizing the fantastic service that you're providing and whether they're in the sense of, you mentioned that, you know, the client versus, you know, or the patient in the psychotherapy relationship, that's relatively well defined. And this is defined in a particular way. We mentioned that the university is the client. And, you know, in the wake of the changes that are evolving in the country vis-a-vis the healthcare reform and who's going to be paying for services, for counseling, and so on and so forth, I'm interested to know how you're formulating or categorizing what you're doing, and how we as a community of universities and colleges can be unifying what we're doing so that there can be some sense of a consistency across the country.
Right. That's a big question. Yeah, you know, I think a piece of it is it really is very much outside of the kind of standard healthcare, psychotherapy care delivery model where you kind of, here's a service and you pay for it at 50-minute hour. It is very much like what a community mental health service agency is doing. It's very much from this, why I talked about it in this broader public health framework for the whole university. I mean, the hard part is there's no structure in this country of how do you pay for public health interventions. That those things are very much outside of the standard care delivery system. And so that's the thing that we're struggling with too. I mean, we are funded through the university's allocation, through basically tuition dollars, and looking at student health fees. You know, how are you paying for many of these interventions which are there to do preventive work, there to do kind of from a public health perspective, and yet don't fit into this framework. But that's really very much how we're thinking about it. I mean, I think the framework that I put up is really the broader framework of how we think about it and how we respond to these things. You know, in some ways very much like a kind of immunization or other things that are more about preventive. How do you interact with somebody and intervene with somebody before it gets to they need multiple psychotherapy visits or medication visits? That it is kind of those ways in which we're thinking about it. I don't know if that answered your question. But other comments or questions?
My name is Ron Waltmeyer. I'm actually a parent of a child who committed suicide 10 months ago. And every day since then, I've been researching college policies, awareness programs, so forth and so on, including Cornell's, and I commend you for your faculty handbook and so forth that you've created. The problem that I'm finding with colleges is addressing, say, FERPA issues, where parents are allowed under FERPA, for example, to gain access to student records as long as you prove to the university that they're dependent of yours, yet college policies override that aspect of it, require releases in some cases, alcohol, drug violations, including University of Michigan, which putting on this program doesn't notify parents, for example, of alcohol, drug issues, and they've found it's been supportive to have those kind of programs in place. So I guess what I'm trying to address is how as a parent can we create awareness amongst all of us here at a community level to make some changes, I guess is what I'm seeking.
Well, so let me respond to a couple things. I mean, FERPA, I think the interpretation of it has clearly shifted a lot, kind of where the culture has gone. One of the things that we did at Cornell was rather than assuming that students were, we basically assume that they're dependent rather than assuming that they're independent, which changes how, you know, which any college or university can do. You just have to report that to the students, which allows us a little more flexibility to talk to parents. Also, FERPA has safety exemptions, so anything around alcohol use or anything around student safety, universities can be pretty forthcoming. And I think, you know, at our university, that's usually the dean of students. You know, people in counseling services or health service shouldn't be those people because of other state laws and HIPAA and other things that are very clear. But I think FERPA, you know, I think that's one that is being kind of reinterpreted. It was really more about grades, not about conduct or some of these other things. You know, I think you really also talked about issues around alcohol, which is always a challenge for universities. I mean, universities are very protective around many things. Substance use isn't one of them. I mean, universities tend to be environments where students drink more than if they weren't in colleges or universities. I think that's something every parent kind of needs to be aware of too. But you know, involving parents is always a challenge too. I mean, a lot of times we want to see parents as partners, and yet many times our students have issues with parents and family members and struggling with that confidentiality. So, I mean, there's always that tension when someone is going from adolescence to adulthood, and how do you kind of create enough space where they're safe, and yet they still have room to kind of grow and be an adult. But I think there are a lot of ways in which we've looked at that, and that's one of the things that we chose to do at Cornell, to take a little different spin on FERPA which we were allowed to do under the law, and think about it in the opposite way, which allowed us some more flexibility. So I hope that answered most of your questions. Yeah, John?
John Graydon, University of Michigan. So Greg, first, thank you. Second, my question pertains to actually a session that's coming up next, and something that I think all of us will talk about at other times, hopefully during the next day and a half. How do we take what you're doing in a structure and wrap in some peer-to-peer aspects? What we're talking about when we talk about outreach is, who do the students listen to? Right. And we've been spending a lot of time on this, but it's mostly been focused on veterans. We're now trying to start developing it with student populations. And in the peer-to-peer, what you would hear from the returning veterans, including those who are students, is, in their case with the military experience, if you ain't been there, you don't get it. Right. We trust our own. We take care of our own. That's our culture. And the message, if you can finally start training some to participate in actually helping to reach out to those who are struggling, they listen to when it's coming from their own, which is, you're not alone, treatment works, it takes a real sign of, it is a real sign of strength to go get help. I've been there, done that, I'll go with you if you need, let's do it. And actually, it's back to your initial thing that we talked about beforehand, which is the real challenge in some cases with these special populations is getting them in the door. Exactly. Can you wrap in peer-to-peer with your approaches?
Yeah, definitely. I mean, I'm glad to see, I know Allison Melman's here from Active Minds. I mean, that's I think one of the great developments in college and university mental health issues is having those are oftentimes those more informal peer-to-peer situations. We have Cornell Minds Matter, which is a group that's really grown up, much like Active Minds, which I think is essential. I mean, that's a great place to do it. I think there are oftentimes challenges of when do you draw that line of how do you get somebody from that piece where a peer is not going to provide professional counseling or psychotherapy. How do you make that transition? But I think you're right on with the messages you want to give, that I've been there. We all struggle. We all suffer as human beings. Therapy works. It can be helpful. I've benefited from it. The more you can get those messages out, the better. One of the things that we did, which was a mixture of peer-to-peer as well as kind of faculty and staff and our university president, was we developed a video called Real Students, Real Stories, which we showed to all incoming students this fall after the spring suicides. And in it, there were students talking about their struggles. And these are students, many are graduating or, a year or two out. We also had our university president talk about how, he had a difficult period where he sought counseling, he failed a class, he's like, I turned out okay. So you can oftentimes get through this. So those kind of messages from either, people in this role of being very well respected and people who are very close to, I went through this 2 years ago, this is how I got through it. Any way in which you can tell those stories and get people connected, I think, are great examples. So thank you for that question. Sure. Yep, one more. One more question. We have time for one more question. Or no more questions. Thank you very much for your time. Thank you.